Welcome to the Rare Wellness Podcast. The pressures of this modern life, society, and world often steer us toward unhealthy lifestyles. Wellness is a rare treasure hidden in a maze of daily challenges.
In this podcast, we explore uncommon pathways to health and vitality, exploring cutting-edge ideas in regenerative, longevity, and performance medicine, all delivered in bite-sized segments. I'm your host, Dr. Jamie Lewis, and I'm joined today with Becca Babona, one of our regenerative medicine and performance medicine nurses. Becca, good to have you.
Thanks. Glad to be here. Thanks for tuning in, everybody. Before we get started, a quick reminder that this podcast is for educational and informational purposes only. It's not a substitute for personalized medical advice. Always work with a qualified healthcare provider before making changes to your health plan.
What we share here comes from both clinical research as well as our own clinical experience, but everyone's pathway should be individually tailored to you.
Today's episode is all about vitamin D, why it matters for pain, for joint health, immunity, and why most people's levels are nowhere near where they should be.
That's right, Becca. I think this might be one of the most important episodes that we've done because vitamin D literally touches almost everything we do in our clinic. Joint health, hormone health, immune support, and overall well-being. And yet, most patients walk in not even knowing what their levels are.
It's so true. And I think the biggest misconception is that vitamin D is just a vitamin you take for bone health. When patients hear us talk about it in the context of their pain or their immune system, they're always surprised.
Right, so let's set the stage. Vitamin D is technically not a vitamin at all. It's a steroid hormone. Your body produces it when UVB radiation from sunlight hits your skin. It regulates calcium and phosphorus, absolutely, but it also plays a critical role in immune regulation, inflammation, neurological function, and pain modulation. Every cell in your body has a vitamin D receptor. That alone tells you this isn't just a bone nutrient.
And the deficiency numbers are wild. When I pull labs on a new patient, I'm almost always seeing levels that are suboptimal. We're not talking about rare cases.
No, not at all. The data tells us roughly 1 in 4 Americans is below 20 nanograms per milliliter, which is the deficiency threshold. A 2025 review published in Nutrients estimated around 60% of Central Europeans fall below that same mark. But here's what most people don't realize. The standard reference range says normal is anything above 30. At our clinic, we're aiming for optimal, which is 50 to 80 nanograms per milliliter. That's a very different target, and it's where the meaningful clinical benefits start to show up.
And that's a conversation we have almost every day with patients. Their primary care doc says their D is fine at 32, and we're looking at that same number saying there's a lot of room for improvement.
Let's talk about pain, because this is something that's hugely relevant to our patient population. A lot of the people who come see us are dealing with chronic pain, back pain, neuropathic pain, musculoskeletal pain, and there's real data connecting low vitamin D to these conditions.
What does the research actually show?
There's a major meta-analysis by Wu and colleagues published in Public Health Nutrition in 2018. They looked at 81 observational studies, totaling over 50,000 participants, and found that people with arthritis, muscle pain, and chronic widespread pain had significantly lower vitamin D concentrations compared to people without those conditions. The odds of being vitamin D deficient were consistently higher in the pain groups.
So there's a clear pattern, but does fixing the deficiency actually change the pain?
In people who are truly deficient, yes. There's a striking case published in the Permanente journal. A patient with severe neuropathic pain, numbness, hyperalgesia, couldn't walk without a cane. His vitamin D came back at 6 nanograms per milliliter, critically low. They started him on a high loading dose of D3, 300,000 IU, followed by 5,000 IU daily. At 1 month, his neuropathy had improved dramatically. He dropped the cane, started walking on the treadmill, went back to training with kettlebells.
That's one of those cases where you just wish every primary care provider was checking vitamin D on patients with unexplained pain.
Exactly. And the mechanism makes sense. Vitamin D acts as a neuroactive steroid. It influences how pain signals are processed in the nervous system. It also inhibits prostaglandin E2, which is PGE2, one of the primary drivers of inflammatory pain. A review in the International Journal of Molecular Sciences laid this out very clearly. Vitamin D modulates prostaglandin release, affects T helper cells, and influences nitric oxide synthase. These are all key players in the pain cascade.
So it's not just correlation. There are real mechanisms.
There are. Now, I want to be balanced here. A 2024 meta-analysis of RCTs looking specifically at chronic low back pain found that vitamin D supplementation didn't significantly reduce pain scores overall. But the critical detail is that many of those trials included participants who weren't deficient at baseline. The evidence is strongest and most clinically relevant in people who are actually deficient. That's why we test, not guess. Now let's talk joints. Osteoarthritis is the most common musculoskeletal disease worldwide, and we see a lot of it in our clinic. Becca, what are you seeing when you pull vitamin D on these patients?
It's almost always low. And these are the patients who are dealing with knee pain, hip pain, stiffness, and often they've been told just to manage it with NSAIDs, but nobody's checked their vitamin D.
That's a missed opportunity. Vitamin D is directly involved in joint health through multiple pathways. It maintains calcium homeostasis for bone metabolism and cartilage function. It modulates inflammatory cytokines, specifically TNF-alpha and IL-6, which are major drivers of cartilage degradation and joint inflammation. A narrative review in Nutrients found that patients with low vitamin D status, below 50 nanomoles per liter, showed improvement in joint pain with supplementation.
And the clinical trials?
Mixed, and I think we need to be honest about that. A 2017 meta-analysis of randomized controlled trials found that daily doses of 2,000 IU or more improved WOMAC pain and function scores in knee OA patients. But a separate single study at the same dose didn't replicate it. Here's where it gets interesting though. A 2024 study published in Scientific Reports using data from the Osteoarthritis Initiative found that higher vitamin D levels were significantly associated with lower WOMAC pain scores in male patients across multiple statistical models. But that association wasn't found in females.
So there may be a sex difference.
Possibly. The researchers noted that males generally engage in more physical activity, and physical activity synergizes with vitamin D for musculoskeletal health. It's a reminder that this isn't a one-size-fits-all story. The other thing that matters is body composition. Obese patients with knee OA and low vitamin D had significantly more disability than obese patients with healthy vitamin D levels. Vitamin D is fat soluble, so people with higher body fat effectively need more to reach the same serum levels.
That's something we talk about a lot in our in-body assessments. Body composition drives so many of these conversations.
Let's shift to autoimmune conditions, because this is where the vitamin D data gets really compelling. Rheumatoid arthritis is a completely different animal from osteoarthritis. It's the immune system attacking your own joints.
And we know vitamin D is a big piece of the immune puzzle.
A huge piece. A 2025 randomized, double-blind controlled study published in BMC Rheumatology looked at 100 RA patients. The group receiving 4,000 IU of vitamin D daily for 6 months showed reduced pain and improved disease activity scores compared to placebo. Multiple other RCTs have shown that vitamin D supplementation lowers inflammatory markers in RA, DAS28 scores, CRP, and ESR.
And then there's the VITAL trial, which is kind of the big kahuna.
It really is. The VITAL trial was conducted through Brigham and Women's Hospital and Harvard Medical School. Nearly 26,000 participants, 25,871 to be precise, men aged 50 and older, women aged 55 and older. Randomized, double-blind, placebo-controlled. The vitamin D group, taking 2,000 IU daily, had a 22% lower rate of confirmed autoimmune diseases compared to placebo. That includes rheumatoid arthritis, polymyalgia rheumatica, autoimmune thyroid disease, psoriasis, and inflammatory bowel disease. Published in the BMJ in 2022.
And didn't the effect get stronger over time?
It did. When they looked at just the last 3 years of the trial, the vitamin D group had 39% fewer confirmed autoimmune disease cases than placebo. That's substantial. The lead researchers, Dr. Karen Kostenbader and Dr. Joanne Manson, were very direct about the clinical implications. Kostenbader said she now recommends 2,000 IU of D3 daily plus 1,000 milligrams of omega-3 fatty acids to her patients for autoimmune disease prevention.
That's coming from Harvard Rheumatology. That's not fringe medicine.
Not even close. This is as mainstream and evidence-based as it gets. Let's zoom out from autoimmunity to the broader immune picture. Becca, when patients come in and say, "I get sick all the time," or "every cold knocks me out for 2 weeks," What's one of the first things you're thinking?
Check the D. It's not the only thing, but it's one of the first things I'm looking at. And so often, there it is, low.
And there's good reason for that instinct. Vitamin D is a genuine immune regulator. It influences both the innate immune system, your first line of defense, your macrophages and antimicrobial peptides, and the adaptive immune system, which includes your T cells and B cells. A 2025 review in Frontiers in Immunology details how vitamin D modulates T cell populations, specifically decreasing Th17 activity, which drives a lot of autoimmune and inflammatory pathology, and helping restore CD4 to CD8 balance.
I think what's important for patients to understand is that vitamin D isn't just boosting your immune system, it's calibrating it.
That's the perfect word. You don't want an immune system that's just turned up to 11, that's autoimmune disease. You want one that fights when it needs to fight and stands down when it needs to stand down. Vitamin D helps with that calibration. It enhances antimicrobial responses when you're fighting an infection, and it dampens the overreaction that causes collateral damage to your own tissues.
Which is why it's relevant to the respiratory infection conversation too.
Absolutely. The link between low vitamin D and increased susceptibility to respiratory infections has been established for years. It became very visible during the pandemic, but this is not new science. Vitamin D supports the production of antimicrobial peptides, enhances macrophage function, and helps prevent the cytokine storm pattern where the immune response does more harm than the pathogen. Okay, Becca, let's get into something that I think will be new for a lot of our listeners: injectable vitamin D. Most people are familiar with capsules and pills, but there's a whole other delivery method that's underutilized.
And it's something we offer in our clinic. So walk us through it. What is it and how is it different?
Intramuscular vitamin D3 injections deliver a large bolus of cholecalciferol directly into the muscle tissue, typically the deltoid or the gluteal muscle. The key difference from oral supplementation is the pharmacokinetics. When you take vitamin D orally, it's absorbed in the gut, passes through the liver, and a portion gets metabolized and inactivated relatively quickly. With an intramuscular injection, the vitamin D deposits at the injection site and acts as a depot, a slow-release reservoir that gradually releases into the bloodstream over weeks or even months.
So it's like a time-release mechanism, but in the muscle.
Exactly. A study comparing oral versus intramuscular vitamin D found that while the oral group had a higher initial spike, the intramuscular group had higher sustained levels at 12 weeks, 25.5 versus 16.7 nanograms per milliliter. A Korean randomized controlled trial published in Osteoporosis and Sarcopenia tested a single 200,000 IU intramuscular injection and found it was safe and effective, with 73% of participants reaching adequate levels by 24 weeks. And Gorman and colleagues published in the Journal of AOAC International showing that a 600,000 IU intramuscular injection effectively raised levels for months without any metabolic abnormalities.
Who is the best candidate for injectable vitamin D versus just taking a pill?
Several populations. First, people with malabsorption issues, celiac disease, Crohn's disease, inflammatory bowel disease, or anyone who's had bariatric surgery. Their gut may not absorb oral vitamin D effectively. Second, people who've tried oral supplementation and just can't reach adequate levels despite high doses. We see this more than you'd think. Someone taking 5,000 or even 10,000 IU daily and their levels barely budge. Third, compliance. If someone simply will not take daily pills consistently, a single injection every 3 to 6 months is far more reliable.
And from a practical standpoint in the clinic, it's quick. It's a simple IM injection, maybe 5 minutes of your time, and you're covered for months.
The safety data is very reassuring too. Across multiple clinical trials, intramuscular vitamin D injections were well tolerated. The main side effect is mild injection site soreness, which is temporary. Calcium levels stayed within normal ranges. The depot mechanism actually works in your favor from a safety perspective. You're not dumping the entire dose into the bloodstream at once. It releases gradually.
But you still need to monitor.
Absolutely. Any high-dose vitamin D intervention should be done with blood monitoring. You check the level, you intervene, you recheck. That's personalized medicine. That's what we do here. Let's bring this home with the practical stuff. Becca, if someone is listening right now and thinking, okay, what do I actually do? What's step one?
Get tested. Ask your doctor for a 25-hydroxy vitamin D blood test. It's simple, it's cheap. Don't assume you're fine because you take a multivitamin or you spend time outside. Know your actual number.
And remember, the target is 50 to 80 nanograms per milliliter, not above 30. That's the standard reference range, but it's not where the best outcomes live. The Target D trial, presented at the American Heart Association in 2025, specifically aimed for 40 to 80 and found a 52% reduction in recurrent heart attacks. That's the range where things start to really move.
For supplementation, always D3, not D2. That's important. Recent research showed that D2 supplements can actually lower D3 levels, which is the opposite of what you want.
Take it with food that contains fat. It's fat soluble, so absorption improves with dietary fat. A typical dose for someone who's deficient is 4,000 to 6,000 IU daily to start, then you retest in 8 to 12 weeks. Maintenance is usually 2,000 to 4,000 IU daily, but it varies enormously. The Target D data showed that over half of participants needed more than 5,000 IU per day to reach optimal levels. That's 6 times the FDA's daily value. One size does not fit all.
And if oral isn't cutting it, come talk to us about the injectable option.
Or if you just want the convenience and reliability of not having to think about it every day. Either way, test first, intervene second, retest third. That's the protocol. Becca, if you had to give our listeners one takeaway from today, what would it be?
Know your number. Vitamin D is one of the most impactful and affordable things you can optimize, and most people have no idea where they stand. If you're dealing with pain, joint issues, or you're catching every cold that comes through the office, get your vitamin D checked. It might be a huge piece of the puzzle.
Couldn't agree more. And if you're in the Spokane area and you want to get a comprehensive look at where your vitamin D stands alongside your full metabolic picture, that's exactly what our Vitality Evaluation is designed for. Same-day labs, a full consult, and a real plan. You can find us at c4rpm.com or spokanehrt.com.
Thank you, everybody. This is Dr. Jamie Lewis reminding you that your body holds incredible potential to heal, thrive, and perform. Sometimes it just needs the right tools to unlock its full potential and help you live your best life now. We'll see you next time.
See you next time.